Thank you for joining us for the COVID-19 daily media call for April 28th. Governor Walz will not be joining us on today's call. Today's agenda will start with an update on the COVID-19 outbreak from Minnesota Commissioner of Health Jan Malcolm and Infectious Disease Director Chris Erzman. Following that update, we'll focus in on two related updates to testing. First, we'll hear from MDH Assistant Commissioner Dan Huff on the progress of the testing ramp-up announced last week. Then we'll hear a brief update from MDH State Epidemiologist Dr. Ruth Linfield about serology testing in the context of the COVID-19 response. Following those opening comments, we will open it up for media questions. With that, I will now turn it over to Minnesota Commissioner of Health Jan Malcolm.
Thank you, Mike. Good afternoon, everyone. Just a quick data update as usual. Globally, as of early this morning, we did pass the 3 million case mark and over 211,500 deaths. In the United States, we're fast approaching, and I'm sure by now have passed 1 million cases and over 56,000 deaths. Here in Minnesota, we reported our by far largest increase in confirmed laboratory cases, up 365 positives from yesterday to a new total of 4,181 cases. As Chris Erzman will probably remark, a lot of that is due to the intensive testing that's going on in certain regions of the state with outbreaks associated with food processing. We have a new total of 301 deaths in Minnesota, up 15 from yesterday. 10 of these deaths, again, occurred in residents of long-term care facilities. I think Chris will also have some comments in follow-up to some of the questions from yesterday about the fact that we know that these numbers, particularly on the case count, are going to rise dramatically, which will have a pretty clear impact on the percentage of cases resulting in death, as we talked about a little bit yesterday. Today's announcement of 15 additional deaths includes 5 in Hennepin County, 3 in Anoka, 2 in Dakota, 1 each in Clay, Crow Wing, Candy, Ojai, Washington, and St. Louis. And demographically, 1 person in their 100s, 1 in their 90s, 2 in their 80s, 7 in their 70s, and 4 in their 60s. As of today, 1,912 patients have been released from isolation. 314 patients are currently in the hospital, 120 of those in intensive care. So we have seen over the last week or so a slight shift toward more hospitalization in the non-intensive care beds. I think with that, I'm going to turn it right to Chris for some additional comments on the increases that we're seeing in testing and what that means.
Thank you, Commissioner. Yes, I just wanted to make sure that we talked a little bit about case numbers. I know that we oftentimes, will get questions from reporters saying, well, you were seeing 100 cases a day and now it's jumped up to 150, or you were seeing 200, and what does this mean? And so I want to acknowledge that with the increase in testing, both with the governor's goal of increasing testing, and so, opening that up to some extent, as well as with the intensive testing that has been done at various agribusiness plants across the state, we are seeing a big increase in our case numbers. And so we want people to know that that is happening, that when you see additional cases, that's to be expected. With more testing, we will see more cases. And so I want to lay that out, that in the next number of days, we are going to continue to see more and more cases. And people should not be shocked or concerned, because as you recall, when we were talking about our cases earlier in the pandemic, when we had less testing capability, we talked about how each case represented just a portion of what was really happening in the community. Now that we have more testing, we are having a chance to actually measure what's happening in the community. So I want to put that in context so that people understand that there will be more cases. And then we did get a specific question yesterday about the fact that the deaths in Minnesota represented a higher proportion of cases than were being seen in other states. And I did comment that, part of the reason for that is because our testing has been so targeted. We have prioritized individuals in long-term care settings for testing, and as a result, we have been testing a higher proportion of very vulnerable at-risk individuals who are predisposed to more severe disease and unfortunately death. So the numbers that we were seeing were not a true representation of an assessment of the total population. And as an example of that, yesterday our deaths represented 7.49% of our cases, and today, with increase in cases in other sectors of our population, that has dropped to 7.14%. So we will continue to likely see that change as we're doing more and more testing in what would be considered a less vulnerable population. So just wanted to bring those 2 points to your attention, and I will now turn it over to Assistant Commissioner Dan Huff.
Thank you, Chris. Good afternoon. Good afternoon, everyone. Wanted to provide an update on where we are in our testing strategy as we launch what Governor Walz describes as our moonshot to increase testing statewide to everyone that needs it. A week ago, we reported 927 tests done in a day. And since the governor made his announcement, we have exceeded 2,000 tests a day. And today we are reporting 2,412 tests being done yesterday. So more than doubled from a week ago. That's good news. We're not where we need to be on testing. We know that this is a ramp up. It is not something that you flip a light switch and it comes on, but rather we are increasing capacity every day. Some of the major accomplishments in this agreement are, one, is that we now are developing an integrated testing system statewide with every healthcare system in the state. So instead of only being dependent upon your particular healthcare provider, we now have a statewide network so that if one provider is low on capacity, we're able to tap into others. And by contracting with Mayo and the University of Minnesota, we are opening up that excess or surge capacity. We do have a testing coordination center that is working with representatives from our various healthcare organizations and Mayo and the university and MDH to make sure that we are integrating and providing testing statewide that people need. We've launched a website where clinics can send us their information of where they are doing testing. That website changes every day as clinics come on board, or if they run out of supplies, they may go quiescent until they are able to get supplies again. So check that website for any updates as those occur daily. We're also now beginning to ramp up the other parts of our testing program. One is looking at contact tracing. As Chris Erzman discussed some of the work that they have been doing, she and her team are an amazing group of hardworking disease investigators. However, we are now moving into unprecedented levels of testing, and we will need to have unprecedented levels of case investigators. So we're beginning to ramp that up, training more people within the department, training people in local public health as we expand that network. We're also looking at how do we target our priority populations. We know in recent cases, and as Chris described, we have hotspots in long-term care, in our food production, and these are all priority populations that we are looking to test. We want to test people in congregate care settings, long-term care, prisons and jails, homeless shelters, etc. We want to test people experiencing homelessness. We want to focus priorities on communities of color because we know that they have been disproportionately impacted by this virus nationwide. We are looking at testing workers in our critical infrastructure, utility workers, transportation workers, our child care workers, people involved in food production or in working in the grocery store. All of these workers are critical to the daily functioning of our society, and we are prioritizing them for testing as well. As we develop this moonshot approach, we will have some, jumps and starts as we launch into this. We're making good progress. We're by no means where we want to be. We do not have the capacity to test everyone that we want to test today, but we have doubled that since a week ago, and we will continue to increase that. Thank you. With that, I'm going to turn it over to our medical director and state epidemiologist, Dr. Ruth Linfield. Dr. Linfield is going to talk about one segment of testing or one category of testing that we're hearing a lot about, and that is serology. Dr. Linfield?
Thank you very much, Assistant Commissioner. We have been getting a lot of questions about serology, and so I thought it would be useful to spend a little time to explain what serology is and limitations and potential uses. So what serology does is it measures antibody or an exposure to something. And in order for one to measure that, it takes a little bit of time to build up antibody. There are different types of antibody, IgM, IgG. It can take about a week to be able to measure the IgM levels. It can take 2 to 3 weeks to peak the IgG levels. And so depending when after exposure one does the test, one may or may not be able to detect antibodies. Another issue is whether the antibody is protective or not. And there are certain kinds of serological tests that are measuring antibody, but they are not measuring what we call neutralizing antibody. In order to do that, you need to have cells that have virus growing on it, and you put the person's serum at different dilutions, and you see if the antibody that is present can prevent that virus from replicating or neutralize the virus. And that can help us understand, does someone have protective immunity? It's not an absolute correlation, but it is a good one. There are not many tests that have viral neutralization. Most of these tests are just measuring whether there is binding to a viral protein. We also don't know if someone who has antibodies, they're exposed to COVID, to the virus that causes COVID-19, if they will be protected from disease. People are actively doing research on this now, and we just don't have that information yet. We also don't know if there is protection, how long it lasts. Does it last for 6 months? Does it last for a year? Does it last for 2 years? We don't know. This is something that we are all learning. So how do we use antibody tests against SARS-CoV-2, the virus that causes COVID? Well, right now, a good use would be to understand on a population level how many people may have been exposed to this virus. And that can help us understand the scale of the current pandemic in Minnesota communities. Another use is there's a research study going on right now on utilizing people who have had laboratory-confirmed SARS-CoV-2 infection because they were PCR positive, and it is looking at whether using their convalescent plasma to help other patients who have COVID-19. And for that purpose, it is helpful to figure out who has antibodies. We do not know at this point in time how to use antibodies for individual decision making. And that is because of a number of things. Number one, there are now more than 100 serological tests out there. They have a variety of performances, and some are not as accurate as others. And in fact, there is a national group that is evaluating the various tests that are out there. But even if you have a test that has very good sensitivity, so it can detect the antibody, and very good specificity, which means it's detecting SARS-CoV-2 and not one of the other human coronaviruses, or not cross-reacting with something else, the accuracy is going to vary with how many people have been exposed, because these tests are not 100% sensitive or 100% specific. And when there are fewer people in the population who have been exposed, the chances are that the positive is a true positive, or what we call the positive predictive value, falls. And we will have a certain number of people who test positive who aren't truly positive. And finally, the other thing is, again, we don't know what it means. We don't know if somebody has antibody present. We cannot say that you are not going to get infected again, because we don't know that. We don't know if you get infected again, you may still be able to shed virus and transmit to other people. So at this point in time, really the uses for serological testing are for seroprevalence, and we are going to be doing some of these studies in Minnesota to determine how widespread the infection has been, and for use for identifying persons that have an antibody response that can serve as convalescent plasma donors. Thank you.
Thank you, Dr. Linfield. As we start the question and answer session, we'll ask that reporters limit questions to one primary question and one follow-up, and that you limit multiple questions from each media outlet so we can field as many questions from as many outlets as possible. With that, operator, we're ready to take questions.
Thank you. Ladies and gentlemen, as a reminder, to ask a question, you may press star and then the number 1 on your telephone keypad. Your first question comes from the line of Tim Nelson from NPR News. Your line is open.
Hi, thanks for taking the question today. Senator Housley has suggested that the state should test all residents and workers in long-term care. You mentioned that Chris Ayresman or Dan Hall in talking about priority testing. Are you thinking about responding to this or making this a priority to do universal testing in these long-term care facilities as we're seeing them become real hotspots?
Hi, this is Commissioner Malcolm. I'm going to turn that to Chris in just a minute for comment, but I just learned of Senator Housley's suggestion just a little bit ago and have not had a chance to talk to her yet. I think building a little bit on what Dr. Linfield was just saying, I think we, and she was talking in the context of the serologic testing. Chris may have additional comments on the optimal use of PCR testing as well. But the fact of the matter is we're still, as we're ramping up testing volumes, we're still in the position of needing to set some priorities for testing. So it might be a laudable goal to move toward broader population testing in these particularly vulnerable settings, but it just in complete candor, it would not be something we'd be able to do immediately with the available capacities. Chris, would you want to comment further?
Thank you, Commissioner. I'll just add to that by saying that we have been prioritizing testing in long-term care facilities for the last number of weeks, and we are continuing to do that. And that is focusing on individuals or situations in which we identify residents who may have symptoms compatible with COVID or staff members. And so we continue to see this as a priority population for testing because of their vulnerabilities. But as the Commissioner said, capacity is not yet where it needs to be to say that we would just do widespread testing across the board in every facility simply because of those limitations. The other consideration that we always want to keep in mind when we're doing testing is that testing is not just a question of getting a result. There are implications with those results, not only within the facility that help us with cohorting and isolation and all of those things, but we have to make sure that we have plans for staffing, or when we're testing in plants that we have, if people need housing, to ensure that they can isolate or quarantine safely, that we have plans for that. So we always want to make sure that when we're engaging or preparing to do widespread testing, that we have considered all of the other necessary supporting factors that have to be in place when we do that. So we want to do that. We want to do more testing, and we want to make sure that when we engage in that testing, that we have all those supports in place so that it can be successful all the way around.
And this is Dr. Linfield. I just want to add one additional piece to it, that when you do a PCR test to see if someone has an active infection, you're looking at one point in time. So if they are negative today, that does not mean that they're not incubating the infection and that they would be positive in a couple of days. And so we have to know how to use the testing and also how to follow up and work with people who have had significant exposure. Because testing someone while they're in the incubation period doesn't mean that they are not out of the woods. And so it has to be used carefully and in context. Thank you.
I just have to. I'd ask if that isn't a better alternative to the emergency shutdowns and evacuations that we've been seeing in some of these centers. I appreciate the need for planning, but that isn't how it's been working out either.
This is Chris Ayersman. I'll just comment that some of the challenges have been because there has been insufficient staffing to address some of the testing that has taken place. So we want to make sure that we have thought that through.
Thank you.
Your next question comes from the line of Jeremy Olson of Star Tribune. Your line is open.
Yeah, hi. One of my questions had to do with the accuracy of molecular diagnostic testing, not in just the sensitivity and specificity, but in the percentage of people who end up with positive tests. I mean, it's been about 10% or less every day of test results resulting in positive cases being found. Given that you're working with high-risk populations, are you surprised that rate is that low? Do you expect that to change? Maybe talk a little bit about that positive testing rate.
I would ask probably Ruth and Chris both, if you'd like to comment on that.
I can start, and then Ruth, if you want to follow up. Sure. I can tell you that the testing that we've done in certain populations has yielded a much higher positivity result than what you gave. So when we're doing testing in a setting that we're aware of transmission, we're seeing very, very high positivity rates. But even so, with our testing in long-term care, we're seeing much higher rates than we might have expected if we were, testing the general public. But I'll let Ruth comment.
Yeah, I was going to say a very similar thing, that, it's a different statistic if you're looking at what is the proportion positive amongst all the tests that are being done, because not all of those tests are done in high priority populations or people with whom we have a very high index of suspicion of having COVID. And when we do testing, say in a long-term care facility that does have other tests, as Chris says, the proportion positive is quite a bit higher. And so it really depends on the population.
Gotcha. Quick second question. With respect to discoveries of these outbreaks in long-term care facilities, have you guided long-term care facilities on how and when they're supposed to disclose deaths or outbreaks to residents and to their family members? Is there a standard way of doing that? We've heard some irregularities on when families are learning that there have been deaths and cases of involving COVID-19 in facilities where they have loved ones.
I believe we have given some guidance on communications to the facilities. Chris, can you comment on that?
Sure. Yes, we have, with every time that we have a situation in a facility, as we've talked about, we assign a case manager. We're working with them on a regular basis, and we do provide them with materials that they can share with residents, families, as well as talking points. So we have guided them on the importance and given them some tools that they can use on the importance of being transparent and providing information. That is not something that we can control in terms of how they use those tools, but we definitely are providing them with tools and information that they can use in communicating both with residents and family members, because we think it's important that they're doing that.
Thank you.
Your next question comes from the line of Emily Havoc of Care 11. Your line is open.
Hi, thank you all for taking my question and taking the time today. This would actually be for Dr. Linfield. Thanks for joining the call today. I kind of want to use your time since you're here to ask you to just expand a little bit on, you talked about antibodies and that we don't really know how protective those are and how much immunity someone might have. From a layperson's perspective, I think it seems like we're putting a lot of stock in that hopefully being true. So can you explain why we at least are hopeful that will happen? And I guess, looking at, we don't know that much about this virus, but looking at similar viruses, do we see those same antibodies being protective? Can you kind of walk us through just the basics of why we're looking at these and why we think that they may offer some immunity?
Sure. I do need to just say this is a new virus, and so we are really learning as we go. But certainly there are other viruses for whom let's take measles virus. If you've been exposed and you've had the disease, or if you've been immunized, you do develop very strong protective immunity against having disease or infection again if you are exposed to measles virus. We do know that there are other infections, though, that the immunity is much more short-lived. Some of that is because there are changes in the virus, such as influenza, which is another type of RNA virus. Coronavirus is an RNA virus, but influenza has the capacity to change more frequently, and that's why every year we come out with a new vaccine because of the point mutations that occur in the virus. are hoping with coronavirus is that there will be protective immunity, because that is what is going to get us out of this pandemic, when there is a high enough proportion of the population that has protective immunity, then transmission of the virus fizzles out. And oftentimes we would see that if, for example, we have an effective vaccine. Let's go back to measles. If we know that having 92% of the population either have had infection or have been vaccinated and have mounted antibody, then measles doesn't circulate for extended periods of time. It will go and find the person who has not mounted antibody, and it may infect them, but it doesn't keep going around and around. And that's why we have been able to eliminate measles from the U.S. We don't know what that proportion of population-based immunity is. This has also in the past been called herd immunity with COVID. It depends a bit on how transmissible it is. It depends a bit on how long-standing and effective the protective immunity is. Some scientists have estimated that it needs to be in the rate of 80 to 90%. And if that is the case, we really hope that we will have an effective vaccine, because that will be the most effective way to ensure high rates of immunity in the population and that the virus does not continue to circulate. So hope that's helpful.
Yeah, I think it is. Just a follow-up question, Dr. Linfield, how hopeful are you right now, given what you know, that these antibodies will be significantly protective?
So this is a hope. This is not science, and this is my opinion. I am hopeful. I think, though, that it may not be the case that it will have lifelong immunity, but I am hopeful that there will be immunity for a period of time. But this is something that we really have to be very careful about, because at this point in time, if I had, say, a healthcare worker who had PCR positive infection with SARS-CoV-2, I would insist that that person wear the same personal protective equipment as someone who did not have laboratory confirmed SARS-CoV-2, because we do not know at this point. And so we have to be really careful. This does not mean if someone has had it and they have a positive antibody test that they don't have to social distance anymore. We just don't have that information, and the stakes of making a mistake are too high.
Thank you very much.
Your next question comes from the line of Matt Savick of Minnesota Public Radio News. Your line is open.
Hi there. You've probably heard the news that President Trump is signing an executive order requiring meat plants, meat processing facilities to stay open as critical infrastructure. Given what's happened at plants here in Minnesota and across the border in South Dakota, how big of a risk is this to require these plants to stay open?
Well, this is Commissioner Malcolm. I'm going to invite Chris and Ruth to comment on this as well, but it certainly seems, while we appreciate the importance of these industries to our farmers and to the food supply at a time when we're seeing such explosive increases in numbers of cases and the impacts on surrounding communities, it seems problematic, to say the least. I haven't seen the order. I don't know if it also requires plants to operate differently or at lower capacity, or any of the strategies that could possibly mitigate risk. So I should probably reserve further comment until I know the specifics of the order. But it seems counterintuitive on the level of just what's happening with the outbreak, but understanding that these are very important industries and everyone wants to see them operating as soon as and as safely as they can. But Ruth, Chris, thoughts?
Yeah, this is Chris Eiersman. Definitely, with the testing that we've done in Nobles County with JBS, we have found a very large number of positives. We recognize that there's interaction both with individuals through their employment as well as in the community. Nonetheless, we definitely know that there's transmission that is occurring in the plants. And so there are a number of considerations. In the case of JBS, they have employees who need to be out of work because they tested positive and are isolated. And so that's going to be a challenge going forward in terms of wanting to reopen just because of the employees that are not able to work. I think we want to make sure that any industry that is essential and continuing to work is able to do so in a manner that keeps their employees safe. And so I, too, just got an email that came to my account just as we're talking here and with this, and I haven't had a chance to look at the details either, but I think that, as the commissioner said, we are very committed to making sure that these essential workers and essential services continue, but we want to make sure that we're doing it in a manner that is safe for the employees. And so we'll have to evaluate this more, but we do know that we have situations in which there has been transmission, and so we're going to have to make some changes in order to make sure that we're doing things that are best for the industry as well as the employees.
And if you don't mind, I have another question related to hospitalization, specifically the survival rate for people on ventilators. Do you know what it is, or is that something that the MDH is keeping track of?
We are doing extensive evaluation of hospitalized cases, and so I can check to see what the latest data are. If you want to reach out to Mike Schomer, we'll get that to you, looking at what we're seeing currently in terms of individuals who have been on ventilators.
Okay, thank you.
Your next question comes from the line of Bill Werner from Minnesota News Network. Your line is open.
Hi, thank you very much for taking the question. I want to put this in perspective of the percentage of deaths that we have had in Minnesota at long-term care facilities. I think it's just under 80%, 77%. And I understand what Dr. Linfield is saying relative to incubation periods and accuracy of tests. But given that those long-term residents are being hit so hard by this, does it make sense to perhaps waste some of those tests to perhaps save some additional lives? Now, I understand that those folks are perhaps going to die at higher rates than the rest of the population. That's an unfortunate reality of this. But does it make sense to put more resources there even if we're wasting some of the tests? Second part of that question is, if you get to 20,000 a day, how soon are you going to get to 20,000 a day? And if you're at 20,000 a day, would you feel comfortable with universal testing or nearly universal testing at long-term care facilities?
This is Commissioner Malcolm, and I'd certainly invite not only Ruth and Chris, but Dan, if you're still on the line, to comment as well. The goal is, I think, of when we described when we announced the testing partnership, is to build the capacity to do 20,000 a day within the next 3 to 4 weeks. And as I said, as with all new ventures, we're working out some logistical kinks, not ramping up quite as quickly as I had hoped, but we're expecting to get more precise forecasts of day-to-day or week-to-week growth that we can share with you soon. But the goal is to get to 20,000 within the next month. At that point, but then again, I think those estimates of what we thought we needed will continue to evolve. And I think, as the governor said, it's not so much about a specific number, but about learning what we need to test smartly and to meet all the goals of being able to appropriately treat people, appropriately identify and respond to hot spots, and do the kind of surveillance testing that would let us get a more accurate picture of the spread of the disease throughout the population. But as we have more hot spots, and what's happened in the food processing sector, I think has happened quickly and of a scale that we didn't anticipate. So I'm just going to reserve the right a little bit to maybe recalculate what we think our need might be. So to answer your question about once we get to 20,000, does that mean we can do universal testing here, there, or the other? That's just, I don't feel good about giving you a definitive yes or no without kind of revisiting some of those estimates of what we need the testing for. But Dan, I'd invite you to add any thoughts if you have any.
Well, no, Commissioner, I think you said it well. It is a moonshot. We don't get to the moon overnight, and every day we're working with our partners to add more capacity. We have a whole team of folks that are working on nothing but sourcing additional lab supplies, both collection and testing supplies. We're working with Minnesota-based manufacturers to do production as well. So we're doing everything we can to increase capacity as soon as possible. Part of your question was, whether it would be throw it away tests. We want to test everyone we can. As Chris mentioned earlier, our residents of long-term care have been a priority from the beginning because we have seen them as our most vulnerable population and those who need to be the most protected. And that's why we have done much more intensive testing in long-term care. We are still prioritizing folks in long-term care. And in fact, our own public health lab is dedicated to just that population, testing people in long-term care. So we've reserved that full capacity for that population. We have a number of priority populations. We have our long-term care. We have the folks in food production, the meat plants that you mentioned or another reporter mentioned. These are all priorities, and testing is an important part of this. It's not the only strategy because we continue to have our old boots on the ground epidemiology, which is if people are symptomatic, they need to isolate themselves. And if we have people in these populations that are symptomatic, they're isolated. So testing is definitely an important part of the strategy, but it is not the only part of the strategy.
And this is Ruth, and I just wanted to add, again, and reinforce that long-term care absolutely is a priority for us. I was just talking a little bit about the limitations of testing on any particular day. That one needs to have an approach, and you need to do follow-up. You need to put measures into place so that people who have the virus are not transmitting it to other people. So there are a whole series of interventions that need to come together, and we are working very hard with our long-term care facilities, and we are also working with them around what are best practices for using the personal protective equipment so that our healthcare workers who are in long-term care don't get infected, working with them about best practices for when and how to cohort patients or resident. There are many layers, as Dan alluded to. So we are very concerned and working very closely with long-term care. I just wanted to make that clear.
I just want to be sure that I'm understanding what Commissioner Malcolm said. It sounds like, Commissioner, you're saying that ultimately when you reach the goal of 20,000 tests per day, or whatever the goal is in 3-4 weeks, that how those tests are allocated is still going to be dependent on hot spots, on what's happening in food production, the other various critical areas, in addition to long-term care. Am I understanding you correctly, Commissioner?
Yeah, yes, Bill, that's what I said, is that just in
Very
terms
good.
of the target number of how far does that 20,000 number get us toward all those multiple goals. I just would like to revisit that with the team to see, based on what's evolved in the last couple of weeks, if our estimates of what the goal should be may have changed.
Okay, thank you. I appreciate it.
Your next question comes from the line of Dave Orick from Pioneer Press. Your line is open.
Hi, thank you. So I know it's ahead of it, but from where you guys stand from a testing standpoint, will we be ready Monday to reopen the next level of things?
Commissioner Malcolm here. That is certainly one factor that the governor will be considering. How much progress are we making on testing, and how quickly do we expect that to be ramping up? But it's not a singular factor in his decision. So I can't I can't say that if we're at 4,500, he would say no, and 6,000, he would say yes. I think it's going to be much more complex than that. We are still, as we've discussed, in a growing phase of the epidemic. So trying to balance all those considerations will be important.
Thanks. And just to follow up on something that's been discussed earlier and was asked yesterday, the percentage of those who are dying who are in long-term care seems to be high in Minnesota. So this is not dealing with targeted testing, I don't think, unless you think our deaths are not a representative sample. But why do we think we're having such a high proportion of deaths in long-term care versus the total number of deaths?
Well, I'm not sure if it was a question of the number of deaths in long-term care compared to all deaths, as it was deaths in long-term care compared to the number of tests.
No, the first.
Yeah.
I'm sorry. Right. The number of deceased in long-term care as a percentage of the total number of deceased.
Right, and I don't know, Chris or Ruth, if you have the national comparable figures on that, but I think it's so that we can answer that question. If not right today, we can get you that. But I do think it's as we I think said yesterday. We think it's also a function of doing a pretty good job of protecting the general population from the spread of the disease so far, and really good access to health care in general. For the folks who are still at risk due to underlying conditions, but may not have the same combination of risk factors given their age. But Ruth or Chris, would you have any other comments on that?
Well, this is Chris Ersman. I just want to clarify, we've talked about the fact that the proportion of total deaths that are related to individuals who are have been residing in long-term care is very high, but we've explained that that's because we are doing a disproportionate amount of testing in that location. So what I wasn't clear about was, are you asking why we're seeing, a high proportion of our deaths in long-term care? If so, the answer is because that is where we have been focusing our testing for the last number of weeks. If you're saying, is the proportion of deaths to residents with cases in long-term care different than what we're seeing in other places, that would be something we will look at and get back to you. I just wanted to clarify kind of what the ultimate question was.
Yeah. The ultimate question should not have anything to do with the fact that you're focusing testing, diagnostic testing, on long-term care, because it's about people who are dying. Does that make sense?
But the people who are dying are getting reported and attributed as dying from COVID because we've done the testing. So if that makes sense.
It does make sense. That surprised me, but that raises the idea that you think it suggests that there would be a lot of deaths, more than just a handful of deceased people who are not being reported as COVID deaths because they were never tested.
No, I don't think that's the message that I'm intending to send.
Okay, I didn't think so either. Okay, we'll move on.
Yeah, I think it's an important question, and we want to make sure we understand the question correctly and that we can get you the right answer. I think, I do not know the demographics, and I'm just wondering if Ruth or Chris do know the demographics of the deaths nationally. What percentage of those deaths nationally are among the elderly, or specifically among residents of long-term care or not long-term care, if we have those comparables to other states. I thought that the question yesterday was more about the number of deaths among long-term care residents as a percentage of the total laboratory confirmed cases, and that looking to be particularly high, and that we tried to answer that one. So we can make sure we could get clear on what your question is and get you the right numeric comparisons with other states. But I still kind of feel like we're comparing apples to oranges a little bit in our answer here.
Operator, we have time for one more question.
Your next question comes from the line of Jennifer Mayer of WCCO. Your line is open.
Okay, I just had a follow-up to the first question about Senator Housley's suggestion for universal testing in long-term care facilities, as well as a comment that was made after that saying that we haven't had the staffing to do all of the testing. One of her suggestions is looking at other states that have deployed National Guard soldiers to assist in long-term care facilities to help with testing and staffing shortages. Is that something that we are looking at doing here to help with the testing in those places and the staffing?
Commissioner Malcolm, we have had a couple of specific incidents so far where the Guard has helped with some emergency staffing needs. So we're continuing to work on not just, I think I might have mentioned this earlier in the call, a lot of work really is going on around the response to individual facilities with individual crisis situations, and we're working hard to come up with more of a statewide plan that would perhaps get more clear on what role the Guard can play, perhaps in both the testing and the staffing situation. So rather than kind of one facility at a time, we're trying to simultaneously be helpful to each facility and try to, kind of come up a level and think about a more statewide response as well.
So what needs to happen, I guess, to kind of get this plan in place, and how quickly can this happen?
We're working on it right now, and I think we've mentioned before that we have a team from the CDC that's visiting Minnesota. Ruth, maybe you might want to comment quickly on what conversations you've had with them, but we're looking forward to some recommendations from them to inform that plan. Ruth?
Yes, thank you. We have had the team here for about 2 weeks, and they have been helping us assess long-term care facilities. They've gone out with us on a number of visits, and we are coming up with tools and criteria for best practices. And as you might imagine, it's a very complicated situation. There are staffing shortages for a number of different reasons, and we are trying to address some of these reasons, including that is an extremely stressful environment to work in. And so one area that we are trying to do is we do have a behavioral scientist as part of the team who is helping us strategize to boost the and improve the ability to work under such a stressful situation. We are also working with facilities to look at ways that some facilities have been very successful in limiting transmission and trying to understand what were the procedures that they did that can be applied elsewhere. And as everyone knows, the residents in these facilities are so frail and fragile, and they vary. Each facility is different, and the ability to move residents around and be successful in that, or move them to an alternate facility, all that varies depending on your patient population. And so we're really trying to come up with ways of assessing each facility and ways of strengthening that facility and its ability to respond. And the other thing that's really hard with these facilities is that we can't put a bubble around them. I wish we could. That would be the best way to strengthen this very fragile and vulnerable group. But healthcare workers come in and out. And in fact, there are some patients who need to go out for dialysis. And so really working hard to find ways to limit movements of people, limit interactions with people, it is something that we are continuing to examine and to refine and to figure out ways of continually checking on who may be getting infected and how transmission may be occurring. It is really important, though, for everyone, I think, to recognize that it is so hard for these residents, and we have to continue to protect them for an extended period of time until this virus is no longer widely circulating in the community. And so this is not a simple thing that you just do testing one day and it's not in the facility and then we don't have to worry about it. We have to constantly be on guard, and that makes this tough. This is going to be going on for a really, really long time. Thank you.
Thank you for that. And one last follow-up with that is we're talking about the number of tests increasing in places where we're having our priorities set. I know we're up to, we've increased our testing just from a week ago. To get to Monday, do we think we'll have 5,000 tests to be able to do at some of these priority places or just across the board in Minnesota? The 5,000 the governor has been looking forward to kind of reopen the state.
I'm sorry.
Okay.
Go ahead, Dan.
Go ahead.
No, please go ahead. I didn't catch the first part of that question. Sorry.
So first of all, the 5,000, as Commissioner Malcolm mentioned at the beginning, or to an earlier question, the testing is one part of what we are looking at as we reopen the state. We desperately want to let people get back to as much normalcy as possible, but that has to be within the confines of good, sound public health guidance and protecting people. We are looking at a number of factors for reopening the state, and testing is but one of them. Will we be at 5,000 by Monday? I can't answer that. We're ramping up throughout the system. Every healthcare system is ramping up their internal capacity. Mayo and the U are working feverishly to ramp up their own capacity. I can't give you a number as what we will be at on Monday, but I suspect it'll be higher than where we are today.
Thank
That
you
is
very
all
much.
all the time we have for today's call. If anybody has follow-up questions, feel free to reach out to MDH Communications at 651-201-4989. Thank you for your time today. We'll talk to you again tomorrow.
Find more local news stories at ccxmedia.org and follow us on social media.